Maximizing. There we go. Oops. Oh, there it is. Okay. Let's see, we got 13.
Okay, Dr. Auerbach, it's 8 o'clock, so I'm going to introduce you.
Thank you.
So everyone, welcome to the Grand Rounds. Of course, this is Dr. Williams speaking, the program director for our residency program here in pediatrics. I'd like to introduce you today, Dr. Stephen Auerbach. He grew up in New York City and received his MD and his PhD from Columbia University. He also completed his residency in pediatrics at the UCLA. And recently, he's reached his mandatory retirement, 30-year retirement. He served for a long time as a pediatrician as well as a career officer and a medical epidemiologist with the U.S. Public Health Service. First with the CDC and then with the HRSA. He's a longtime member of the board of directors for New York Metro Area Chapter Physicians for a National Health Program, the Nationwide Health Professionals Group advocating for a single-payer national health insurance, also known as Expanded and Improved Medicare for All. And he's going to talk to us about the single-payer national health insurance today. And so please welcome me, all of you, and welcoming Dr. Auerbach. And thank you so much for talking with us today.
Hi, folks. I'm having a little bit of trouble while I'm sharing, also bringing up the chat. So my apologies for that.
So Dr. Auerbach,
yes.
The chat, when people put in messages, it'll appear on the chat.
Okay.
And you'll be able to see them, and you can respond to them like that. So anybody who wants to actually ask a question can ask that way, or you would have to unmute yourself.
Alrighty. So
and you can ask for questions at the end.
Okay, super. So I'm just going to plow through my slides. It's a little of a, we're all dealing with Zoom and everything else. But you see my contact information here. I'm happy to answer questions at the end, assuming I can get the chat back, or you can all jump in. Let me get through the slides to sort of systematically get through the material, and I think answer a lot of questions that might come up along the way. So yes, I'm Dr. Steve Auerbach. Thank you for joining me. Thank you for the invitation. So what I'm going to present today, and you should have the learning objectives and other material I sent, is a thoroughly one-sided but thoroughly evidence-based case for single payer. Oh, now I see chat. Then I will discuss at the end what I think the counter arguments are, both valid and invalid. But let me make the case for why it's the best proposal out there for solving the healthcare crisis, both for the American people, the people living in America, as well as doctors and hospitals. So I like to, you see, I was with the U.S. Public Health Service as a uniformed service officer. I am a patriot, and so you will see throughout some of this a red, white, and blue theme for what you might call the All-America Plan, to put a good spin on it, also known as Medicare for All or Expanded and Improved Medicare for All. When internationally, we would just refer to as national health insurance, and a certain technical term, single payer, which has some important meaning, and I'll explain all of those things. If you're interested in joining any of follow-up listservs, you'll see the pnhpmetro.org/join. Is for the New York area Metro chapter. Similarly, .org, the pnhp.org is the national. And there is a single payer bill in the New York State legislature at a state level, the New York Health Campaign.org. And if you scroll down towards the bottom, there's a sign up there too. So, disclosures. I have no financial interests, commercial interests with anything. I'm a volunteer on the board of directors, and actually, as a not-for-profit, do-goodnick organization that doesn't take any money from pharmacy or from any of the drug companies or insurance companies or any other businesses for that matter. I'm actually expected to fundraise and chip in. So, some background. How do we get so? We need to talk about the underlying purpose of insurance as an underlying principle of insurance in order to understand why the fragmented for-profit health insurance system that we have cannot work. So the point of insurance, whether it's health insurance or insuring your car or your automobile, or for that matter, malpractice, is to spread the risk. That's what we refer to the insurance pool of money is. So everybody is paying into the pool every month, and only a small percentage at any given time need to tap into the pool and use it. That's the whole point of insurance, is to spread that risk over a large number of people and, in a sense, over time. Everybody paying in monthly and only some people needing it at any single point of time. So whether your house burns down or you have a heart attack, it's only a small percentage of folks who need to pay out while everybody else is paying in on a small stream, steady basis. So you can see right away that the most natural and efficient pool is for everybody to be paying in all the time. And so that's why we call it single payer. Everybody's paying in, and there's one insurance pool that then is paying out, a single pool paying back out. And it's also why one of our slogans is actually also an important econometric policy point, that it's everybody in and nobody out. Everybody's paying in and nobody's excused from paying in. So, what is the business of the for-profit, private, corporate Wall Street health insurance companies? Well, their actual business is to collect money to create an investment pool for Wall Street. And healthcare, in a sense, is their loss leader. In fact, their term for it officially is medical loss ratio. So every time they pay out to provide health care, that's a loss for them. And in fact, the only way they compete, seriously, the only way they compete, as opposed to some of their marketing claims, is actually to avoid covering sick people. So the way they make money inherently, and that's why it's a fragmented system competing against each other to essentially not cover sick people. We like to sort of say that what their goal is to cover the healthy and the wealthy. So how did we get where we are today? So in World War II is really when there was the rise of the current system of employer-based private group health insurance. And the reason for it, in part, was that there was a wage freeze during World War II. Unions had gotten stronger under FDR, really for the first time. But instead of being able to negotiate on the basis of salaries during the wage freeze during the war, they were forced to negotiate on the basis of benefits. And one of the major benefits became having employer-based private group health insurance, where your employer paid part of the premium and you paid part of the premium as the employee, plus the fact that you were eligible for this group meaning the pool. But of course, each employer and each insurance company would have their own little pools rather than one big national pool to spread the risk maximally. So who isn't in that system? Well, if it's employer-based health insurance, who's not in it? Well, first of all, the elderly, the retired, and those who are chronically not in the workforce due to chronic disability. And so we bring in Medicare, as well as Medicaid, to cover poor people with originally poor people who also had children or other dependents. In the terms of the time, the deserving poor. So these would be folks who either weren't employed for whatever reason, perhaps they were raising a child and needed to do that rather than be in the workforce, or they were part of a small employer that didn't cover them and only paid them piecemeal, etc. So then we come up to the ACA, and at the time of the ACA, it does a couple of things. First of all, the big thing it does, frankly, is Medicaid expansion. That both increases the eligibility, the threshold, the floor, if you will, of what percentage of the federal poverty level people would be eligible for. And it also does away with the other requirements, because Medicaid before the ACA was not actually a program for poor people. It was for poor people who also had met other criteria, and such as having dependent children. And the Medicaid expansion did away with that. The other thing is that if you were not eligible to buy into a group insurance pool, because let's say your employer didn't offer it or you were self-employed, buying into non-group health insurance is way too expensive, as you would think about that, going back to that first principles of spreading the risk across a large pool of people paying in. So if you weren't eligible for any other pool, under the ACA, what it created essentially was, well, if you are a resident of New York State, then you can buy on the New York State Marketplace Exchange, and your pool, in effect, is I'm in New York State and I'm not eligible for anything else, and so I can buy the New York State resident pool, in effect. And so it created access to group health insurance, still private, through private for-profit insurance companies, still fragmented, many different uh, pools and groups out there, but at least meant you could buy group health insurance if it wasn't otherwise available to you, rather than being dependent on buying solo insurance, which was completely impossible to pay for. The trade-off is that it also offered some reforms in terms of um, a guaranteed issue, which that's the no pre-existing conditions exclusion. So if you already have asthma and 2 heart attacks and cancer, the insurer still has to offer you access to the plan. It can't refuse you outright. Um, and also community rating, which is critical and sometimes forgotten about under the pre-existing conditions exclusion. So it's no good if the plan has to offer you and be willing to sell it to you, the group health insurance, if you have pre-existing conditions, if your premium is based on your individual situation. So they could say, yeah, sure, we'll sell it to you, but it's $50,000 a month or $100,000 a month, because you're a bad risk, because you're already have had heart attacks and cancer and asthma. So yeah, sure, the government's forcing us to sell it to you, but we're going to make it a high premium. And so that's the community rating piece. There's also issues around annual lifetime caps and including family members up to age 26, although there's lots of escape loopholes on most of these issues. So regressing here, not accidentally noted in red, is continued attacks on the ACA, continued attempts to do more privatization using public money to subsidize the for-profit insurance companies. The ACA does that already with the premium support. So for those folks that are getting some taxpayer dollar to help pay the premium, on the one hand, that's a good thing for being able to access buying the for-profit insurance plan. And on the other hand, it's also taxpayer money subsidizing, creating essentially a guaranteed subsidy of profit making for the insurance company, which is somewhat questionable. And the other is this idea of offering low-cost plans, which are low cost in terms of the monthly premium, which is great until you actually get sick and discover that they have super high deductibles, super high copays, and narrow networks. So they're fine until you get sick, and then your out-of-pocket costs when you're sick, you suddenly discover it's so-called junk insurance. So that's one side. Another side is to tinker with incremental changes. We'll talk about public option. It's also one of your handouts of why public option is not such a great idea. But basically incremental changes, but leaving in place the fragmented pools, the on and off coverage, just basically a complex kludge or a Rube Goldberg system, as we used to call it. And also higher costs because there's higher overhead, as we'll see, and so on and so forth. And then starting in 2015, frankly, with the Bernie Sanders campaign, the pre-existing movement that had already existed for 20 years, 30 years for single payer, really going back to the Carter administration and the Kennedy challenge to Jimmy Carter, um, was the modern single payer movement, but it goes mainstream, gets much broader attention starting in 2016 and ever since. So what is it? We need to be clear what we're talking about here. So what we're talking about with single payer, improved and expanded Medicare for all, is publicly funded, privately delivered. So the insurance scheme, if you will, the financing behind the scenes is publicly funded through progressive taxation, but the delivery system, unless
Oye, a lo mejor te puede buscar aquí a Trump hablando
if you could mute yourself, unless
cómo se busca ya.
if you could mute yourself, unless you're trying to address a problem with my presentation. Thank you. So the private hospitals, the private doctors still remain in place. So they're essentially, it's the best of capitalism in the sense that the doctors and the hospitals are now competing to take patients. So one of the key things is it's replacing the flat tax of premiums, copays, and deductibles with being paid for by progressive taxation. So what I mean by flat tax of premiums is if you're super rich or middle class, or hello, I've been muted now. Hi, I'm now unmuted. Hopefully it's working. Can you hear me?
Yes.
Okay, thank you. Is everything okay?
Yes, I was trying to mute the other person and I accidentally muted you, sorry.
No problem. Just want to make sure we're okay before plowing on. I promise this is my wordiest slide. The rest are lovely graphics. All the providers take the same insurance. All the patients have the same insurance. It actually increases the freedom for the patients. There's no more narrow networks. Every doctor takes it. Every hospital takes it. Every patient has the same plan. It's progressively paid for in the sense that it's paid for progressive taxation. Right now, premiums, copays, and deductibles act as a flat or regressive tax. If you're super rich, you pay the same premium for the same plan as you do if you're middle class or working class. And so it's a much higher percentage of your income being paid to premium for working class and middle class than it is for the rich, which is the opposite of what it should be. Very critical, although Medicare for all is sort of the political term that's been adopted recently, it is not current Medicare as it is, just expanded to age 0. Because current Medicare as it is has huge gaps. And in fact, the actual legislation calls for massively expanded and improved benefits. So again, the existing legislation, the ones that all the economic analyses that I will be showing after this, cover all medical, dental, mental, hearing, vision, drugs, devices, and very importantly, maybe less obvious for pediatricians, but with our aging population, very importantly for long-term care. As I said, prepaid for, we're not talking about free. It is, of course it's paid for. It's paid for the same way that we pay for current Medicare and Social Security, the same way we pay for our police and our fire and our military and everything else. It's it is essentially a political choice what our government gets involved in and covers. No premiums, no copays, no deductibles, no surprise bills. Freedom of choice for the patients. All the hospitals and doctors and other healthcare providers and pharmacies take it. And security for patients in that you just have it all the time, always, regardless of any changes in employment or changes in life circumstances. So that's the, if you will, moral argument for it, that access to healthcare should be a communal public good, not a private commodity to be purchased, like some widget du jour, such as the various screens and phones, and whether you have, a Toyota or a Mercedes-Benz. And we like to sometimes make a comparison to the way the fire department works. You know, if you are going along life and you have your apartment and everything's good and you're paying your taxes and life is good, and then all of a sudden your house catches fire. The firemen come, they put it out. You don't pay a premium. You've already paid for it in your taxes. You don't have to do a copay or deductible. You don't have to pay off the firemen before they will start putting off the fire. You don't have to pay them off after they put off the fire, but before they'll let you back in. Um, it's just a communal good that the fire department is always there, and they come and just put out the fire. So, what are the current issues? So, one of the current issues is the remaining uninsured. And I say that's only one of the issues. Um, and almost in a sense, it's a lesser one. So, before the ACA came in, we were running along somewhere at a low of about 50 million to a high of about 55 million uninsured. That's completely uninsured, no Medicare, no Medicaid, no nothing. With the ACA, it's been roughly cut in half. And at the time, around 2017, some of you may remember the Congress and the president at that time were threatening to take away the ACA. And we said, oh, that's immoral to throw 25 million people off of health insurance. But if it was immoral to do that, I would suggest it's still immoral to be leaving 25 million still without health insurance despite the ACA. So who are those people without health insurance? There is a misconception that they are entirely people who are ineligible for assistance due to their immigration status. That nationwide is simply false. That's about 16%. The remaining uninsured includes 25% of the folks nationwide who are actually eligible for the ACA subsidies but still not enrolled. The system is just too damn complex. The eligibilities change every year. People go on and off, on and off. They have to navigate a certain amount of complexity rather than just guaranteed coverage to get into the system, and they have to make a choice of still paying the remaining premiums, which again, if they're low income, may be a serious issue. There's 25% that are eligible for Medicaid in their state, but not enrolled. Again, on, off, complex system. Many people not tapping into the benefits that they are eligible for. 15% are ineligible for the subsidies because their income is just a little bit too high, but they still consider the premium unable to pay for. That's what the individual mandate was supposed to push them into. But many people just forego it because the reality is that the premiums are too damn high. And the system too complex to deal with. 9% are ineligible subsidies due to the fact that they have an offer of employer coverage. So they're eligible for coverage through their employer, but they've declined it because their part of the premium is still too high. And 9% are ineligible for Medicaid because their state hasn't adopted the ACA Medicaid expansion. And 16% are ineligible for assistance due to immigration status. Now, these are nationwide numbers. In New York State, it's a little bit better overall for that. And yes, in New York State, a larger percentage is in that ineligible for assistance, but it's still actually well under half. And I would argue that, of course, people should be covered if they are residing in the United States, regardless of their status. In fact, those folks overall are contributing net economically. And in fact, they're usually hardworking, and they're in fact subsidizing everyone else's Medicare. But that's roughly 25 million people. There's roughly 3 times that number, at least, who are underinsured or for whom it's too expensive, even though they're insured. So let's take a look at some of the numbers over time. And this includes everything after 2011 is after the ACA has already rolled out. What you see here at the bottom in the dark blue is the overall inflation rate. In the lighter blue is worker earnings. And then a huge accelerating away from that gap of much faster rising costs of the overall family premium in orange, and the amount of out-of-pocket that the worker has to contribute to that premium, as opposed to, say, the employer, rising much faster. So the ACA did not bend the curve on costs of insurance, and they continue to accelerate faster than the background earnings or inflation. Again, you see here at the bottom in the blue, overall inflation and worker earnings. The family premium is going up twice as fast as that, and the deductibles are going up at several multiples of that. And what that deductible means is that increasingly, even though somebody has insurance, even though they're paying more in the premium, they're having to pay even accelerating more out of pocket when they do get sick to meet the deductible. And the same is going for copays, dropping a little bit as well. So underinsurance, using basically the same measure over time by the Commonwealth Fund, and they define underinsurance as out-of-pocket costs at greater than 10% of income, et cetera, as you can read on the bottom. The key thing is it's using the same methodology over time, and it is increasing, and it's actually continued to increase, maybe not as fast through 2016 compared to 2010 before the ACA, although it's actually increased 2016. We need to update this. It's actually taken off even further again. So that's one part of underinsurance is the premiums are costing too much, the deductibles and copays are costing too much. The other part of it is that you may nominally have insurance, let's say Medicaid, and yet you can't find any doctors who take it. Now, I'm glad to say myself as a general pediatrician that general pediatricians, roughly 75% nationwide of general pediatricians do take Medicaid. But even in the pediatric subspecialties, it's way lower. And what you see here is the number in the darker blue, the percentage of pediatric specialists that take private insurance compared to the percentage that take public insurance by different specialties. And, we know this, that it's a much narrower network of eligibility, which means longer travel time, longer wait time, or no access at all if your insurance is Medicaid. So that's another aspect of the underinsurance. We know that healthcare costs, despite insurance, are a leading cause of personal bankruptcy. 2/3 of those filing for bankruptcies attributed healthcare costs as a major factor. And of those, over 3/4, 78%, actually had health insurance at the time they got sick. Either the medical bills were much too high anyway in terms of the part that insurance wouldn't pay. And then the flip side is when you have employer-based health insurance, when you get sick, you lose your job and then you lose your health insurance. And as we've seen with COVID and the recession with COVID, having employer-based health insurance really makes no sense whatsoever. When you've got mass unemployment, people lose their healthcare coverage as well as their job, as well as their income, and now they're uninsured and impoverished because everything was based on employment status. 57% of people who lost their homes due to foreclosure during the Great Recession actually identified medical debt as a major cause. It's the most common reason for collection calls. Single-handedly, medical bills are 59% of all collection calls, while all other causes for collection calls, telecom, utility, et cetera, are 41%. It's the only category not to vary by income. And infamously, medical bills are the most common reason for personal GoFundMe campaigns in the United States. So we like to say that having private for-profit group health insurance is a little bit like wearing a hospital gown. The chances are your ass isn't covered. Pardon my French. All the things that insurance doesn't cover when you do get sick, the copays, the deductibles, the out-of-network, the unreimbursed, the trade-off of higher versus lower premiums up front, versus having to pay more out of pocket when you do get sick, nominally having insurance, but when you get sick, you still go bankrupt. That's absurd. And then the limited networks of who takes it. I should mention, having worked for HRSA for many years, the health professional shortage areas is basically a measure of too few primary care providers per population in dense urban areas that the HIPS is made to be defined as clusters of zip codes. In more rural areas, it might be a whole county. But the key point here is some combination of travel time and wait time to get an appointment. We have a maldistribution of healthcare providers. obviously Midtown East Side of Manhattan has plenty of providers and others don't. So private insurance is inherently less effective than public. This idea that, oh, government can't do anything right and private for-profit is inherently better is simply false when it comes to health insurance. Going back to that first principle of spread the risk, you can see the most natural insurance pool inherently is, of course, everybody in, nobody out. And then if you're having to do for-profits for Wall Street quarter-on-quarter earnings statements, then your incentive is to deny care to maximize your profit taking. But we also see, just as a matter of comparing Medicaid in the green and Medicare in the blue compared to private insurance in the orange, that the overhead, the administrative overhead of how much goes to pay before they actually start paying any out to providing health care is far worse with private insurance, and ACA has not bent the curve despite some attempts to regulate some of that. And so what you see here is the health spending is going up much faster overall for private insurance than it is for public insurance. Public insurance does control costs compared to private insurance. Here's one reason why. So between the big salaries, the fact that they have to be making a profit for Wall Street because they're for-profit companies, what we see here is Medicare has about a 2% administrative overhead. That means 98 cents out of every dollar is actually going to healthcare, compared to around 85, 87, 88 cents on the dollar going to healthcare with private insurance. We see that the cost of the providing insurance in the United States on a per capita basis is much higher than it is in the other developed capitalist democracies around the world. Their overhead is much less. Much higher percentage of their healthcare dollars actually going to healthcare rather than administrating the financing system. We see here an explosive growth of management of healthcare as opposed to the doctors in yellow. So what this is showing is the increase in health employment, according to Federal Bureau of Labor statistics, people who identify themselves as healthcare managers compared to the number of physicians in yellow. And just an explosive growth, as we've seen with managed care. Well, there's a large number of people employed in that management part of managed care. It doesn't save money, it just redistributes it away from healthcare and towards administration. Duke Medical Center, this was in JAMA. Duke Medical Center, which is actually 3 hospitals making up the overall medical center, has 957 beds in total and 1,600 billing clerks. So more than 1.5 billing clerks per hospital bed full-time employment. Duke's cost for sending bills to one primary care provider, their overhead is $99,000 a year. To do that, again, high hospital administrative costs. The earlier figure was for the overhead on the insurance companies, but for the hospitals, given that they have to deal with, 300 different health insurance plans, just has huge numbers of billing clerks, roughly 9 times the number that, let's say, academic university medical centers in Canada have. Cleveland Clinic, because of pulling nationally and even internationally, has to cover all these many different health insurance companies and health insurance plans nationwide, and they wind up with 3,000 different rate schedules across 70,000 different types of care. So that would be 3,000 different insurance plans and 70,000 different billing codes, and just an insane number. Works out to 210 million different codings for prices. Again, hospital billing. Again, need to make the distinction that earlier figure about, showing about 50% overhead for the insurance companies. This is on the delivery side. For hospitals, they have roughly 5 times the administrative overhead per capita as Canada does. And if you look at the individual physician office, it's also slightly more than 5 times the cost per capita. It's just a simpler system when there's only one insurer out there. And overall, it works out to, if you take overall administrative overhead costs, the hospital, the insurance, and the doctor's piece, it's about 3.5 times. Drugs and devices, we pay more for the same drugs than other countries do. Remember, these are roughly the same drugs, the same statins, etc. The same antibiotics, the same albuterol, what have you, for the kids, let's say, as other countries. But in the United States, we aren't able to negotiate the prices the same way. So in effect, we are subsidizing the excess profit of of pharmaceutical companies, while Canada, Germany, and the rest of the capitalist democracies pay less. There's obviously, the drug companies are still selling to them. They're making some profit in selling to them. They just make an excess profit in selling to us above and beyond that fact. And remember, these are all the same multinational companies selling the same drugs around the developed world. Drug companies' cost structure is, in fact, mostly not research, marketing, administration. That's all the sales rep and pushing it to you. Profit after taxes at 18%. We'll come back to that in a moment. And so-called research and development, 13% by their own statistics. And one could certainly argue that the real research, as opposed to development, is far less. We know that, of course, basic science research, basic pharma research is publicly funded, mostly through the NIH, some through National Science Foundation, NSF. And so the taxpayer is essentially paying twice. We pay for most of the research, and then we pay again to buy the drug, given that the government has issued a patent to it, which again is a government-issued thing. I was talking about the excess profit. So we don't want to put the drug companies out of business. We want them to make a profit. We just want them to make roughly the same profit, as you see here in blue, of the other Fortune 500 companies. Drug companies actually make quite an excess profit, as you see here in the red lines. So again, roughly, as you can see here, somewhere over twice on average what the Fortune 500 average is. And one of the main reasons for that excess profit is that's the excess that we're paying in the United States for these drugs compared to the rest of the developed world, where they can negotiate a fair price. The same is true, in addition to drugs, it's also true for devices. This, your surgeon colleagues might know more about this. Orthopedic implant, it's roughly the same thing. Very little is actual R&D. Most of it is sales and administration and some other profiting. Manufacturing on devices is a bit higher than as a percentage than it is for pharma. So the cost problems in the United States, we pay a higher percentage in GDP overall. It's higher prices. It is not more demand. It's not that we're using more healthcare. It's that our unit costs at every step of the way are far higher than it is for other countries. It doesn't have to be this way. Again, looking at the GDP percentage of GDP, you can see the differences back in 1980 were less overall than it was now, where the cost per capita is accelerating in the United States compared to the other developed world. 2/3 of our spending is already coming from taxes, between the tax subsidy for buying premiums, the government workers having your taxpayer dollar being their employer premium subsidy, VA and various public hospitals, H&H, and then, of course, Medicare and Medicaid. So we're already paying more than the rest of the developed world does in our public spending on healthcare. And then, in addition, we're paying additional amounts on the private out-of-pocket side. An interesting comparison looks at Canada didn't always have their provincial-based public health insurance. They brought it in gradually, province by province, from the early 60s to 1970. And that's right around the time that in the United States, under Richard Nixon, something called the HMO Act was passed, which, despite the name, actually was basically allowing increased for-profit uh, sectors to our healthcare system. So, for example, the private hospital chains that exist in all the other states other than New York weren't allowed to exist. There's various degrees of for-profit that weren't allowed up until roughly 1973, and were allowed thereafter. And what we see is, as a percent of GDP, Canada and the U.S. Were roughly the same amount of spending, and then by the time Canada implements their provincial-based insurance, public insurance, and the U.S. goes to increasing privatization, we see the cost per capita going up, up, up in the United States and more controlled in Canada. It's not a question of better outcomes. In fact, the disparity in life expectancy between Canada and the United States has increased over that same time period from 1 year to 3 years. It's not better outcomes by life expectancy across many countries. So other countries have higher life expectancy than we do. Certainly, it's not better outcomes looking at maternal mortality, which has continued to go down in every other country, and quite frankly, sinfully in the United States, and I use that word reservedly, has gone up in the U.S., where it's gone down in every other Western country. It's not rationing. This is often the claim. It's a false claim for multiple reasons. But the fact of the matter is that other countries provide more hospital days per person than we do. Not rationing on the hospital inpatient side. It's not rationing on the doctor visit outpatient side. Other countries provide overall more care, or roughly the same care in the case of Denmark here, more care in terms of physician visits per capita. It's not rationing in terms of long-term care. Most other countries provide better, more extensive long-term care than we do. There are actually older populations than we have. In fact, in the United States, patients skip care more often, as I'm sure you well know, that patients skipping follow-up or skipping not filling their prescription drugs, etc., because of cost concerns is higher in the United States than it is in other countries. Other countries have more elderly, so certainly it's not a case of they're not having more illness. If you got more elderly, you got more illness. Other countries smoke more than we do. So it's certainly not in terms of all the things that relate to smoking. We do have more obesity, and we do have more poverty. And I would argue that that's not really an excuse for everything else I'm saying here. But if, in full disclosure, those are some other factors too. So we rank last in some composite measures that are done by independent groups. Again, this is the Institute of Medicine. This is not a single payer advocacy group by any means. This is, federal government panel. Ranked us dead last or second to last, 16, 15, 16, or 17th by a variety, an overall score compared to 17 peer countries that you can see at the lower left here, up until public insurance in the United States finally does kick in with Medicare. So this 0 to 64 is the folks who are stuck in the private insurance system in the United States, whereas they are in various public systems in the rest of the developed world. But starting at age 65, the U.S. does pretty well. So once we have Medicare as it is, all of a sudden, our score ranking among peer countries for overall healthcare system delivery is superior, or certainly a lot better than it was, and actually becomes top line as you get into the much older age groups. So there's numerous studies that look at the number of excess deaths due to uninsured and underinsured. Their methodologies vary. The low number is 18,000 excess deaths per year. The debunking study that was published suggested 6% higher mortality, and that was the conservative debunking study. We have 29 econometric studies that show that, and actually 31 now, that show that there's a net savings when you do national health insurance. The references are down below. Where do those savings come from? So this is actually a chart for the New York Health Act, not the national single payer, but I think it lays out nicely the pluses and minuses in terms of costs. So let's take a look actually at the blue for a moment. So obviously, if you're covering everybody, you're obviously going to have increased expenditure. If you're covering everybody and you're eliminating copays and premiums and deductibles, that costs 5.5% more than currently. We're actually assuming improved provider fees overall. So actually primary care providers' incomes go up. And of course, now we're going to also cover long-term care. That's, your nursing homes and your home health aides. So all of those things do cost money, as shown in the blue. And by a center-right group, the Rand Corporation, nobody's liberal, the analysis is that, yeah, it costs $43.9 billion more in New York State, but reduced administrative cost of the insurance side. We talked about that earlier, minus 6.5%. We talked about the reduced hospital and MD office administrative costs. So the first one, the 6.5% here, is the insurance financing overhead reduced. This is the delivery side, the hospitals and doctors reduced administrative costs. And then there's the reduced costs due to paying a fairer price on the drugs and devices. And the total savings, according to a center-right group that was brought in to debunk the New York Health Act, is 55.1 billion savings compared to 43 in increased costs. So actually a net savings of 3.6%, according to the center-right debunking study. So it actually saves money. It doesn't cost too much. This is from a center-left group that was looking at the Sanders bill at the national level out of University of Massachusetts. And again, we see increase in new expenses 12%, but decreased costs 18%, almost 19% in savings. So again, net savings. So our current system, this would be if you take the current system, you leave in place the fragmented for-profit, you don't enact the various cost savings that you get with single payer, but you put in the public option, and actually total costs go up. Plus, you've left in place the complexity of the system and the churn of people being eligible for different stuff and being on and off, and you don't achieve actual 100% coverage, and you still leave in place all of those higher costs out of pocket for people who do get sick regressively. Single payer actually saves money and covers everybody and makes it affordable for far more people. So progressively paid for. What's important about that? So again, as I pointed out before, the difference between, and I'm aware of the time, I think we've got about 10, 11, 12 minutes. The progressively paid for, as I mentioned before, this is how it works. This is actually from a health economist at CUNY, relatively recent data analysis that she did. And this is percent of income spent on healthcare by income group. So the current system is on top, the dark solid line with the triangle carrots, 8.4%, for lower income, 9%, and then it goes down for the super wealthy. So those people that are at 1,000, that are at 1,500%, 1,500% of the federal poverty level, very high income, they're paying far less as a percentage of their income on healthcare compared to poorer people. Poorer people would be paying far less under single payer, as you can see by the crossing lines. Another view of this comes again from the analysis of national bill. Another way to look at it is, well, where's the flip point? So who's paying less? What this shows is that the flip point in terms of, oh, now you're paying more because of progressive taxes is that roughly at the 95th percentile. So 95% of people living in America would pay less under single payer, and about 5% would pay more. And that cut point in terms of what that top 5% is $463,000 in 2013 dollars. The various estimates that are out there, depending on how you do the taxes, and we saw as proposed, let's say by Sanders and Warren, with wealth taxes, it could be as low as 92% or as high as 98% of people would save money under single payer. In the case of the New York Health Act, we have some even more specific numbers. So basically, just look at the right-hand column. This is the monthly premium. So median income around $50,000 a year would be paying $188 a month in their premiums. Go ask your friends and family who are on private insurance what they pay in their premiums. It would be higher for the people over $400,000 in income, and actually it would be nothing for those at $25,000 and less. And again, the point being that this is improved and expanded Medicare, not Medicare as it is just to age 0. Current Medicare has all kinds of deductibles and co-pays. It has additional premiums for add-on insurance that folks may be necessary. All the things that are not covered, dental, hearing, vision, long-term care, they're not covered under Medicare. So the average Medicare recipient is actually paying above and beyond $6,100. And again, all of that goes away, both under the New York Health Act and under the Sanders-Jayapal bill at the national level. Another way to view it is, well, what if we just looked at premiums as a tax? Well, if you look at premiums as a tax, then in fact, the total goes down. And so whether you're paying this, if you're paying $2 to the insurance company, or if you stop paying $2 to the insurance company, but you pay $1 extra to Uncle Sam, which is better? Paying $2 or $1, which is less? So that's the argument about, oh, it's going to raise taxes. Well, yeah, it's going to raise taxes, but it's going to raise taxes more on the wealthy, and you are not paying your premiums, copays, and deductibles and out-of-pocket costs in return. So the big lie is that it's too expensive. The big truth is that it's a net cost savings and also a cost shifting. And I like to say it's kind of a misdirection in the total cost too much. Because when they say it's going to cost too much and they say, oh, it's going to have this big an increase in cost, what they're saying is, yes, whoever the single payer is, if it's national health insurance, then the federal government budget cost is more because that's the single payer. Or if you have state single payer in New York, then the New York state government cost is greater. That's paid for by progressive taxes. And the net for individual families and households is roughly 95% of them pay on net less. It's also lower cost for any business that is a current participant in the system. So we talked about how businesses pay part of the premium for their employees, and they would save roughly $9,000 a year per employee if they're participating and not being a freeloader on the system. And of course, it's also lower costs for all lower levels of government. So if we have national health care, national single payer, the Sanders-Jayapal bill passes, let's say, then states, counties, and cities all pay less. And so their taxes can actually go down. There's 3 essential reasons for this. One is states and counties and cities are employers. So they're paying part of the health insurance for their teachers and their police and their firemen, etc. There's the local charity care. There's the H&H situation, where H&H is covering the completely uninsured under charity care. And there's the Medicaid share. So states actually pay part of the Medicaid piece, traditional Medicaid 50-50 split. And this is actually, in New York State, this is actually a huge piece. The Medicaid share is a huge piece of county level real estate taxes. And those would on average drop in half. So net total savings of money, net savings for 95% of people, net savings for businesses that are currently participating and contributing, um, lower profit margins for the drug companies and device companies, and yes, essentially putting the health insurance companies more or less out of business. There is strong support in public polling for this. This is, again, non-activist polling from regular media groups. And as the word's gotten out, the polling goes up. It's high amongst, even amongst Republicans, it's a 50-50 split. This is The Economist and YouGov. So again, not progressive activists, but neutral parties or mainstream parties. And it's good for doctors, and physician support is growing. Quickly, and my apologies, I'm going to run through these last slides because I know we're beginning to get closer to the end. My apologies. You see here that increased amount of dollars actually goes to the doctors. This is all three of these are actually opposed to single payer. Mercatus is actually the Koch brothers group, showing $681 billion would be going to physicians compared to 668 under the current system, and so on and so forth. Even greater differences with RAND and the Urban Institute's analysis. U.S. physician satisfaction is amongst the lowest on those international comparisons. This has been done repeatedly, and Germany is always the one country lower than us. I don't know the details on that. But certainly higher in all other developed countries, except for Germany. This is a slide showing how much time we're actually devoting to patient care, with all of the desk work and other administrative tasks. And that's not even including the EHR work at night. So only 26% of our work time is actually spent face-to-face taking care of patients. This is compared to Canada, where out of a 40-hour work week, 75% is almost 80% is devoted to taking care of patients, and only 2.4 hours per week on non-clinical administration. This is a really wonderful study. This shows, so it turns out that Epic, the electronic health record, is used in other countries as well. It's used, however, as an actual health tool rather than as an administrative insurance billing and slap your wrist for not checking all the right boxes. So this is the average number of keystrokes or characters in an Epic note in the United States for ambulatory care. And this is what it is in 13 other countries. Basically, there's zero overlap. So three-quarters of our charting is for billing and insurance, not clinical work, using the same Epic system. So again, U.S. physicians are spending a lot of time and money managing the health insurance companies, not the other way around. And in fact, physician support has gone up. This is data, again, from, this is physician earnings. A greater percent is retained, not paid out to overhead. Physician salaries, Canadian physicians make plenty of money. Average for a pediatrician, $298,000 in Canada. And even the surgeons are making a perfectly lovely high income living. Net American physicians practicing in Canada is going up. So there is not a drain of Canadian physicians coming here. It's the other way around. And in fact, the net loss of Canadian physicians going back home, that chart has flipped. So it's much pleasanter to practice in Canada. Physician support has gone up for single payer. This is Merritt Hawkins, a for-profit company engaged in human resources and recruiting, kind of a headhunter firm, among other things. They surveyed and found that 58% opposed in 2008 and 41% opposed in 2017. Support goes from 42 to 56%. And Dr. Carroll and Ackerman have published two studies in the Annals of Internal Medicine showing again rise in support from 49% in 2002 to 59% in 2008, and no doubt it's gone up further since then. They did a nice breakout by specialty and regions, and obviously there are huge differences by specialty and regions. But basically, we would suggest that the impact on physicians is preserved earning potential, increased professional autonomy, increased career satisfaction, decreased administrative burden. We know that the AMA House of Delegates has historically opposed single payer, but they actually came close a year ago, a year and a half ago, where the vote to stop opposing it failed 53 to 47%. So even the AMA, which is only a non-representative 20% of American physicians belonging to it, 47% supported withdrawing the opposition. American College of Physicians, the largest other group, that's all the internists, issued a new policy saying Medicare for all are a strong public option. This essentially is a nice overview of our current healthcare system and its insane complexity and the simplification of public insurance. And some quick links in terms of the group that I'm with, pnhpnymetro.org. And if you want a nice single free download explaining doing all of the Q&As that you could imagine with evidence-based data and references, a free download from the organization called Public Citizen at the bottom, and how to reach me. And I will now stop. My apologies for rushing there at the end and for abutting on the 9 o'clock hour. I will stop talking, and I will stop the share for a moment and open it up so I can see the chat better. I'm not seeing any questions in chat at the moment. If anybody just wants to unmute themselves.
Dr. Auerbach, I just wanted to say thank you so much for this talk. Back. Hello?
Dr. Woolard, I'm not hearing anybody.
Hello? Hello?
Dr. Woolard, are you there?
Dr. Auerbach, can you hear me? Dr. Patel. Hello, Dr. Woolard?
Yeah, I can
Oh, I'm
hear
sorry.
you, Dr. Patel.
You know what? My apologies. My speaker went out. There. My apologies.
Oh.
That was on my end. My speaker turned off.
Okay, so you can hear me now?
Yes, ma'am. I'm so sorry.
Oh, okay. Great. This is Dr. Woolard. I just wanted to say thank you so much for that talk. And you brought up so many important points that are affecting us all, especially in the neighborhood that we serve,
Yes.
where we have so many immigrants and underinsured. The question that I had was in the capitalist government system that we have with such a division in the thought process about how economics would work. Do you think that the single payer system would ever actually be able to pass here?
So you bring up the key question. And what I would say is that there are two valid arguments against single payer. One valid argument is the one that you're implying, which is basically, it's lovely. It certainly would be the best policy. We agree with all of the economics. It'll never pass in the United States. And I think there would be a couple of answers to that. Two answers, essentially, for me. One is, when you look at, if you take away the personalities from electoral politics and you look at issues, it turns out that a large number of progressive issues, including single payer, actually have strong support. I haven't added it yet to the slide set. I just saw circulating in my email yesterday a chyron from Fox News exit polls of the recent national election showing something like it was 35 or 39% strong support and 39 or 35% the other one. moderate support for government national health care. And that was a Fox News exit poll showing well over 75% support. That seems high to me, but whatever 35 and 39 add up to, I'm blocking at the moment. 74? 74. But another example is Florida. Red state voted for Trump, but they passed a $15 an hour minimum wage by a supermajority in the red state of Florida. So what we see is strong support for progressive policies if they are stripped out from, if you will, the partisan personality politics and party politics. There are lots of, if you go to the American Prospect, there's a nice article from a day ago on all of the progressive measures, issue measures that passed nationwide. And to me, the one that sort of was notable was this supermajority in Florida voting for a massive increase in state minimum wage. So that's one answer. Another answer to that question is, well, I choose as an individual, will it ever pass? Why are you banging your head against this? Why don't you fight for some incremental change? And the answer is, well, the incremental change is going to happen anyway. I don't want to spend my time fighting for what's going to happen anyway. I want to fight for what's going to happen at the margin, if you will. Sometimes in political science, I'm blocking on the term, my apologies. But basically, I want to stretch what is possible, and I want to frankly fight for what I think is best, not pre-fight for the compromise that's going to happen anyway. There is another counter argument to the single payer that I consider to have some potential validity. And that is, even if it does pass, the American political economic system is so corrupt that even if it does pass, there would be what's called regulatory capture. That somehow the government regulators would essentially be captured by the corporate interests and screw it up. And this was actually an argument made by one of the leading health economist until he passed away about 1.5 years, 2 years ago, Huey Reinhardt, who himself and his wife, who's also a health economist, helped bring single payer to Taiwan. So he was certainly a single payer supporter in principle. He just thought that America was too corrupt to do it compared to the other capitalist democracies. And I guess the last thing I would say on that one is the economics. I mean, it's just collapsing under its own weight. And we can sort of see with COVID highlighting all of the current problems. And again, I have a whole separate slide set on the issues around racism and how it's improved, not solved, but improved, less bad with single payer, as well as highlighting how COVID has further exposed the flaws of our current system. And one other, just in terms of, nominal support when you're sort of between election cycles, 50-50 support amongst Republicans. Other questions?
Dr. Arbach, can you hear me?
Yes, sir.
Yeah, this is Dr. Patel.
Hi, Dr.
Well,
Patel.
I would just, hi. It was such a complex subject. You made it so simple to understand. I must say that in my 4 decades of medicine, this is the first time I'm hearing it has a lot more advantage on a self-payer compared to this thing. And what Dr. Woolard just mentioned, that was my question. How it can pass through in this politically charged up Senate, Congress, and financially complex situation.
So, if you look at the public support, the polling is slowly going up amongst the general public. It's slowly going up amongst physicians and other healthcare workers. Again, as a single issue, as I said. In terms of the reality of our current political system, that's why I'm an activist.
That's a very, very
I
good point.
would make one other point, and that is New York State has a single payer bill, which is supported by the chair of the Health Committee in the Assembly, Dick Gottfried, and supported by the chair of the Health Committee in the State Senate, Gustavo Rivera. And the final results of the election for New York State legislature aren't in, but it's likely that there will actually be a net more progressive, if you want, left wing, if you want, in the state legislature. The single payer bill in New York State has actually passed the Assembly 4 times. Every time the last 4 times it's come up, it's because of COVID, it wasn't in the legislature in the past year. But I think 2018 or 2019, it passed the Assembly, and the 3 prior years it passed the Assembly. It is 1 vote shy in the New York State Senate of people who've listed themselves as co-sponsors. Prior to the last election, of the remaining Democrats who had not signed on to it, being 1 vote shy, there were 7 Democrats who had not signed on to it, 6 of whom had actually run in the prior election on single payer and then not signed on to it, even though they had run on it. So we would argue that it's actually much closer to passing, certainly in the New York State legislature. Cuomo is behind the scenes blocking it. Pressure. Basically, Cuomo has told the Senate Majority Leader, I'm blocking on her name, Stuart Cousins, to please block it from coming to a vote in the Senate so that he doesn't have to deal with it. But as we've seen with a bunch of other issues like minimum wage, with Cuomo, is he will resist things up until the point that they are likely to pass, and then he'll claim credit for it. Hello?
Hello.
Hi, I'm sorry, were you hearing me, or was I muted?
Yes,
I'm sorry, so I'll stop there.
Hello.
Yeah, Dr. Casano, let Dr. Arbach complete the answer, please.
Oh,
okay.
I guess I sort of
You have a
completed
question.
it. Okay, Dr. Casano, I think I finished the question. So I guess the emphasis would be it's got a quicker, easier path to actually becoming law in New York State than it does nationally. And those who are interested in more information there can go to the New York Health Campaign.
Well, Dr. Arbach, knowing Dr. Godfrey, or rather Mr. Godfrey and Mr. Gustavo Rivera, they are very persistent and very persevered.
Yes.
We have a good, I would say, the ray of hope here in New York State. Thank you.
Yes, sir. And I'm sorry, there was Dr. Casano?
Yes. One is a comment and one is a question.
Yes, sir.
The comment is, Massachusetts has a system like you are mentioning for proposal for New York State. That they'll cover, is a single system or a general covering?
No, Massachusetts very much does not. So no state in the United States has anything like this. Massachusetts basically passed Obamacare before Obama. So what Massachusetts did is they basically passed the expansion, as I explained, with the ACA type expansion that basically leaves in place the fragmented for-profit insurance pools and companies, but with an increased access to buying into that with premiums, copays, and deductibles. The only intermediate version that exists in the United States to a slight extent is in Maryland. They have what's called, I think it's called all payer. And basically what it is that for hospital bills, the insurers all have to reimburse the hospitals the same amount. So whether it's Aetna or Medicare, the reimbursement to the hospitals is the same. That helps a bit for the hospital closures issue and the difference in reimbursements that, let's say, Wyckoff and the Wyckoff case mix has compared to, let's say, Woodhull on one hand and Lenox Hill on the other hand, in terms of the case mix problem for hospitals, but it doesn't solve the overall problem. We
All
used to
right.
have that all payer in New York until Governor Pataki ended it.
Oh, very good, thank you. And
Thank you.
one of the practicality of creating a system is that there is like some practical issue, like a pediatric specialty, like a child psychiatrist or orthopedic, will get $40 for 1 hour intervention visit. How will that change? Something
Right.
as simple
So
as that.
generally, if you look at the other developed countries in Canada, and if you look at the most detailed proposal, which was actually the one from Elizabeth Warren during the primaries, reimbursement rates overall would be roughly at the 110 to 120% of current Medicare. So we're not talking about Medicaid reimbursement rates. We're not even talking Medicare reimbursement rates. We're talking reimbursement rates at roughly at least 110 and up to 120% of current Medicare. Now, exactly how that works out in different subspecialties, I'm not sure, in all honesty. But we do see, for example, even higher than pediatrician support in Aaron Carroll's study, psychiatry overall actually was the specialty with the highest support for single payer. But when we get down to, pediatric psychiatry reimbursement rate per visit, I don't have specific data in my head.
Okay, thank you.
Thank you very much for this detail and information, as well as a very informative lecture. Thank you very much.
Thank you, sir. I know it's after the hour, but I hope that you'll distribute the slides that I sent to everybody, as
All
well
right,
as
we
the
shall.
additional one-page handouts and so on and so forth. And if anybody's interested in joining us, please feel free to do so. The link is there. And you can also contact me at my email. I'm retired, and now that the election's over, this is what I'm doing pretty much full time. So
Thank
you for
so
having
much,
me.
Dr.
Thank you. Thank you.
Back. I'm going to end the call for everyone.